Bismillah ar-Rahman ar-Rahim. Our lecture we talk about gastroesophageal reflux disease اللي تختصر بمصطلح اسمه الجيرد. نسمعون كلمة جيرد يعني gastroesophageal reflux disease. طبعا هذا الريفلكس شنو نقصد به؟ نقصد به انه استرجاع محتويات المعدة من الحامض وممكن حتى القاعدة الى المريء. اوكي. طبعا الجيرد symptoms is very common problem. But occasional episodes is common, and the reflex usually normalized by the peristalsis of the esophagus body. Okay, this peristaltic wave by the esophageal body will clear the acids from the esophagus. In addition to alkaline saliva, neutralize the residual acids, and the symptoms will not or will be prevented. But in GERD, gastroesophageal reflux disease, when developed, the esophageal mucosa will expose to gastric content for a prolonged period of time. That results in the symptoms and even complications like esophagitis. So, why these GERD developed? What are the factors are responsible for the development of GERD? Esophageal motility disorders. Okay. In addition to, if there is abnormality in the sphincter itself, lower esophageal sphincter, when there is a reduce in the tone of the sphincter or inappropriate relaxation. In addition to gastric problem, such as delayed in the gastric emptying, or increase in the acid secretion, or pepsin, or bile, even bile, or there is increased intra-abdominal pressure like obesity, pregnancy, that increase the reflex. And if there is a dietary factors or environmental factors, we will talk about these factors in detail in the next slides. First of all, we'll talk about hiatus hernia, فتق الحجاب الحاجز. Why developed reflex in hiatal hernia? Because we have lost two things. First of all, the pressure gradient across the diaphragm between abdominal and thoracic cavity will be lost by hiatal hernia. In addition, there is an acute angle or oblique angle between the cardia and esophagus also will be lost. There is important features are associated with the regarding hiatus hernia. It's by itself the herniation of the stomach to the diaphragm to the chest. It occurs about 30% of population who have age above 50 years. It's usually asymptomatic, but the main symptoms are heart pain and regurgitation. And there is large hiatal hernia may lead to gastric volvulus. So, these symptoms in hiatus hernia usually develop when there is a large hiatal hernia. So, if we have a large hiatus hernia, we have many patients develop reflex symptoms. But really, there is poor relationship between the presence of the hiatus hernia and the symptoms itself. In other words, a lot of patients with hiatus hernia, they have no symptoms. And a lot of symptomatic patients who have GERD, they have no hiatal hernia or a small hiatal hernia. But almost all patients who develop esophagitis, Barrett esophagus, or vertical stricture, in other way, complication, usually this patient have hiatus hernia. Next factor is delayed gastroesophageal clearance, which means there is a problem in the peristaltic waves or motility of the esophageal body. A defective in esophageal peristaltic activity is commonly found in patients who have esophagitis. But even after a clearance of esophagitis, there is also problem in the motility. Definitely, if we have poor clearance, poor peristaltic wave, poor removed of the acid from the esophagus, this will lead to an increased acid exposure time and more damage to the. Third factor is the gastric content. The gastric acid mainly, most important esophageal irritant, and there is a close relationship between the acid exposure time and the symptoms. In addition to defective in the gastric emptying, There is a lot of patients we have with GERD, they have poor gastric emptying or delay in the gastric emptying, and the reason is unknown. The fifth factor is we have increased intra-abdominal pressure, such as in obesity and pregnancy. These are important risk factors, and the weight loss is very important factors that lead to improving of the symptoms. The last one is the last factor, I mean the exposed to GERD, is the dietary and environmental factor. This is very important, like dietary fat, chocolate, alcohol, and coffee. These things, these factors, these dietary factors, they are relax the lower esophageal sphincter and provoke the symptoms. And there is little evidence about the effect of smoke and acid as a cause of GERD. What are the clinical features of GERD? The major symptoms is the heart pain and regurgitation. Most of the patients they feeling as a burning sensation of the chest in the chest retrosternal. So أكثر من مرة يقول لك أنا عندي أحس حموضة أو أحس حرارة بصدري أو أحس الأكل ده يرجع regurgitation. And these symptoms usually provoked by bending forward or straining by this lead to increase intra-abdominal pressure or lying down. ده أكثر مرة يقول لك أنا أحس بهاي الأعراض عادة بالليل because of lying down. In addition to these symptoms, most of patients they have water brush, which is excessive salivation. Methylmalonic salivation is a protective mechanism to correct the acid. These acids in the esophagus they reflex acid the salivary gland to increase the salivation to neutralize the acid. And sometimes a lot of patients they have history of weight gain. A lot of patients they have night symptoms, even awake the patient from sleep because of choking or coughing due to irritation by the acid, irritation to the larynx and even bronchus. And a lot of asthmatic patients they exacerbating of the asthma. Again, a lot of patients they have developed even complications sometimes of the esophagus like odynophagia or dysphagia. You know what meaning odynophagia is mean pain for swallowing, while dysphagia mean difficulty in the swallowing. And this mainly symptoms develop when there is a complication in the esophagus. Or some patients they develop chest pain, which is usually atypical, non-ischemic chest pain. atypical نقصد به non-ischemic. الفيشر مال ischemic عفوا هذه ثلاثة typical. When we have one or no typical ischemic pain, we call it atypical. Sorry, if we have two of the chest pain, we call it atypical chest pain. This means non-ischemic chest pain. What about the complications? It's very important of GERD. First of all is esophagitis, which is there is a range of endoscopic findings. طبعا esophagitis mean endoscopic finding. ولا شلون نعرف الاسophagitis by endoscope. So it is endoscopic finding. There is wide range of finding from mild redness to severe and even bleeding ulcers or even structure formation. Again, there's poor correlation between the symptoms and endoscopic finding. يعني مرات المريض يشعر عنده أعراض قوية بس بالاندوسكوب نلقي finding mild finding and vice versa. نشوف هذا السلايد هذا typical reflex esophagitis. نشوف هنا linear streaks. هذه نشوفها البيضاء linear streaks of superficial ulceration and extending up. هذا هو junction between the esophagus and the stomach, gastroesophageal junction. نشوف هنا linear streaks of ulceration, superficial ulceration and extend up to the esophagus. What about the endoscopic classification of esophagitis? We have Los Angeles classification. Los Angeles endoscopic classification system for esophagitis. We have 4 grades from A to D. A, if we have one or more mucosal breaks confined to the folds, but it is 5 mm or less. If we have one or more mucosal breaks, but it's more than 5 confined to the folds, grade B. And it is non-continuous between the tops of the mucosal folds. يعني عندنا breaks بس ماكو اتصال بين وحدة وحدة. If we have continuous breaks, mucosal breaks continuous between the top of 2 or more, this is a grade C, but is not circumferential. If it's circumferential, this is grade D. هذا السلايز endoscopic finding. This is grade A. This is a mucosal bricks confined to the folds, and it is 5 mm or less. This is a grade B. It is more than 5. This is 1. This is 2. And there is no continuation between the top of 2 bricks. Here, grade C, there is continuation between the top of mucosal bricks, but is not circumferential. مو كل المحيط مالت الاسophagus. And this is grade D, which is circumferential mucosal bricks. Second complication is Barrett esophagus, which is columnar lined esophagus, which is a pre-malignant glandular metaplasia of the lower esophagus, in which the normal squamous lining. تعرفون الاسophagus normal mucosa هو squamous. When this is squamous change to columnar mucosa, this is we call Barrett esophagus. So it is replaced by columnar mucosa, which is composed of cellular mosaic containing area of intestinal metaplasia. طبعا هذه هي تكون adaptive. This is adaptive response because of a chronic gastroesophageal reflex. عادة هاي asymptomatic Barrett esophagus and usually discovered when there is esophageal cancer. So Barrett esophagus or columnar lined esophagus is a major risk factor for esophageal adenocarcinoma. نشوف هذا سلايد أو endoscopic finding سلايد. نشوف أن هذا هو الgastroesophageal junction. من يكون عندنا columnar mucosa above the junction, this is اللي هو تكون pink columnar mucosa extend above the gastroesophageal junction into the mucosa and change the squamous mucosa. This is Barrett esophagus. هنا نشوف طبعا typical هذا لو نحط اللوس انجلوس grading grade D circumferential severe lower esophagitis ونشوف هنا الاريا. هذا هو Barrett esophagus mucosa and this is squamous esophageal mucosa. The prevalence of Barrett mucosa is increasing. It is more common in men especially above 50 years of old, especially who are drinks, alcoholic patients, and sometimes smokes. There is a weakly association with smoking. Definitely the cancer risk is more closely related to the severity and duration of the reflex rather than the presence of columnar lined esophagus per se. طبعا اكو recent attention همتين هسه حاليا on the importance of the GERD, not only the acids but sometimes bile or pancreatic enzyme or even pepsin. إذن الجهد مو بس الأسيد ترى خلوا بالكم ممكن يكون بايل ممكن pancreatic enzymes or even pepsin. So how we can diagnose Barrett esophagus؟ طبعا هتحتاج أكيد biopsy لأن هو biopsy histopathological diagnosis. When we suspect نحتاج multiple systematic biopsies. This to maximize the chance of detection any intestinal metaplasia and or dysplasia. How we manage؟ طبعا البروتون بامب inhibitors أو عموما الأسيد suppression أو even anti-reflux surgery اللي هي بين قوسين ذني هي management of the GERD. عادة ذني they stop progression of acid regression stop regression or even induce regression of columnar lined esophagus. But these treatments for only to relieve the symptoms of the reflux or even complication of the strictures, but not the Barrett esophagus. So how we can treat Barrett esophagus؟ يعني بين قوسين المانجمنت مال جيرد ما راح تمنع ان ما راح توقف ان البارت esophagus ولا تسوي regression, but they improve the symptoms. Okay, so how we treat Barrett? If we have Barrett esophagus with dysplasia, how we can treat them? The treatment either by endoscopic ablation therapy, radiofrequency ablation, or endoscopic resection, or photodynamic therapy, or even surgical regression, or surgical esophagectomy, surgical treatment. The third complication is anemia. وخاصة type of anemia هنا عندنا هي iron deficiency anemia بسبب chronic insidious blood loss، بسبب erosion، بسبب ulcer موجود برا lower esophagus. هذا راح يسوونه continuous or chronic insidious blood loss. اوكي، وهاي الالسر او الايروجين اذا كانت بالجنكشن احنا نسميها كاميرون ليجن او كاميرون ulcer. Again, one of the important complications is a benign esophageal structure, fibrous structure. وهي طبعا consequence they develop as a consequence of long-standing esophagitis. تعرفون reflux يسوون esophagitis، وهذا esophagitis is inflammatory process اللي healing by fibrous tissue، وهذا fibrous راح يسوون structure in the lower esophagus. طبعا هاي benign condition، ممكن تكون pre-pregnant بس هي per se is a benign structure. So most of them they are elderly, they have poor esophageal peristaltic activity. Usually they develop شنو الفيتشر مالته او symptom هو dysphagia، وخاصة for solid than the for liquid، لان هي طبعا narrowing usually for solid. طبعا اذا كان بلس piece of meat بلس obstruction راح يسوي absolute dysphagia. هاي سلايد راح يراويكم هذا الجدول هو ال causes of esophageal structure in general. شنو اسباب الاسوفيجيال structure؟ من اهم اسبابه هو الجيرد gastroesophageal reflux disease. شوفوا على راس القائمه. طبعا اكو اسباب اخرى هي الويب والرينج، السي اي كارسينوما او اسوفيجاس او كارديا، او extrinsic compression of bronchial carcinoma، او corrosive ingestion corrosive material ingestion، or post operative scarring مثلا سيرجري الاسوفيجاس نسوي له ابليجن او ريسكشن او اي بي جي ارجون بلازما، وهكذا اي انترفينشن ممكن تتحول بعدين الى ستركشر، او بوست راديو ثيرابي راديشن، او بسبب اللونج تيرم انجي انتيوبيشن. نشوف هذا السلايد endoscopic finding. We have A and B. A, both of them they are malignant tumors. A is a squamous cell carcinoma of esophagus. نشوف هذا exophytic mass with ulceration مسوينا راونج. اما البي against mass but is adenocarcinoma جاي من بارت esophagus هاي بالجنكشن مسويته against there is significant narrowing of lower esophageal. هنا نشوف هذا الفوكال كورد، هذا هو الفارنكس. هنا upper esophageal tumor or mass، هذا again squamous cell carcinoma. الكومبليكيشن الخامس هو الجاسريك فالفولس. ذكرون واحدة من الكومبليكيشن اوف هيات الهرنيا ممكن يؤدي للجاسريك فالفولس. So massive intrathoracic hiatal hernia ممكن twist upon itself. Okay, and this will lead to gastric valvulus. طبعا السيمبتومز راح تؤدينا طبعا بالنتيجة إلى complete esophageal or gastric obstruction، بالنتيجة راح تسوي severe chest pain, vomiting and dysphagia. طبعا diagnose كل سهل بعد chest x-ray راح نشوف air bubble in the chest or barium swell. How we investigate patient with the GERD؟ هنا خلوا بالكم if we have young patient and he had typical symptoms of GERD and there is no worrying features، ما عندنا ريد فلاج فيتشر او الارميك فيتشر مثل ويت لوس مثل ديسبيجيا انيميا، وخاصه اذا كانت ايرون ديفشنسي انيميا. طبعا هذا نقول عليه جيرد without complication with young can be treated empirically without any investigation. نعطي بي بي اي ولايف ستايل موديفيكيشن. But if we have elderly, middle or old age patient, especially if he have symptoms alarmic features, alarmic symptoms or worrying symptoms or red flag symptoms like weight loss, bleeding, dysphagia, iron deficiency anemia, or any suspicion of complication is present, here we have to investigate, and the investigation of choice is endoscope, upper endoscope. What about the lifestyle modification for reflux esophagitis؟ طبعا احنا المانجمنت اوف جيرد يكون بس باي ميديكيشن. Here we have lifestyle modification، تغيير نمط الحياة. What are these lifestyle modification؟ First, we can elevate the head of the bed 6 inches. احنا قلنا ذكروا الفيتشر مالت الرجاج والهارتن عادة by lying down or by bending. During sleep, if we elevate the head of the bed, this may decreasing the feature or symptoms of the GERD. In addition to stop smoke, stop excessive alcohol consumption, reduce dietary fat, reduce meal size, avoid bedtime snacks, weight reduction, and this is very important, especially if we have overweight. Avoid chocolate, coffee, tea, cola beverage, tomato juice, citrus fruit juice, and avoid, when possible, some medication that lead to increasing the GERD symptoms like anticholinergic, thiopylline, diazepam, narcotics, calcium channel blocker, beta-adrenergic agonist, progesterone, some contraceptive medication, alpha-adrenergic antagonists like phentolamine. The most broadly applicable recommendation is weight reduction. What about the H2 receptor antagonist drugs? They may help, but they are usually they are not healing the esophagitis. So they are helping the relieving of the symptoms, but are not recommended if there is any such complication of esophagitis. So what we give? Proton pump inhibitors. They are treatment of choice for patients with severe symptoms and if we have complication like esophagitis. Symptoms almost invariably resolved and esophagitis healed in the majority of the patients if we use PPI, proton pump inhibitors. Recurrence of the symptoms is common when the therapy is stopped, and some patients require lifelong treatment at the lowest acceptable dose. Here we have to use after 3 months of PPI use. We should use as needed and as lower effective dose as possible. So another slides, this will be algorithm for treatment of gastroesophageal disease in a step-down approach. First, we start with the symptoms. If we have symptoms of GERD, we start with the antacids, but again, PPI is a treatment of choice in a full dose. If we have good response, we can put in maintenance dose, as we say, in lower effective dose, and as needed after complete the course of treatment, and then we can continue with the H2 receptor antagonists and antacids as required. If we have patient poor response, here we may have another diagnosis. We have to think about the other differential diagnosis, especially if we have normal pH monitoring. So we have to consider pH monitoring. If it's normal, we should think about the diagnosis. We should think about other differential diagnosis. But if we have positive pH monitoring, here we have confirmed the diagnosis of GERD, and if they are not responding to full dose of PPI, we should consider surgical treatment fundoplication. And thank you. This is an example of a question we can give to you as essay, short essay questions in the last slide. And thank you.